Let's talk about tennis elbow or lateral epicondylitis, or just pain on this part of the elbow, whether you play tennis or not. And before we talk about that, maybe it'll be beneficial if we talk about the idea of variability. What do I mean by variability? Well, it's the ability of accessing a variety of possibilities, in this case, possible strategies, to manage our stressors. So when we're in relationship with a stressor, we need to be able to load and unload our systems so that we could adapt to any given stressor or stressors. So that's a great example of what's going on with elbow tendinitis or tennis elbow in general. There's some kind of a loss of variability in the system of the body, and where they're having the symptoms is the compensation. And when it comes to a point where it's chronic and it's been treated and it keeps on recurring even with rest, that's a great example of somewhere else in the system just isn't able to adapt. So the nervous system, the brain, sticks to what it knows, irregardless of how the severity of the symptoms are. Okay? So one of the things we have to understand is basic anatomy and biomechanics of the involved structures. So in this case, I got my arm, the right arm here. This is the front of the elbow, this is the back of the elbow. In general, what happens with tendinitis or lateral elbow issues is that the triceps, which extend the elbow, they also have a function of external rotation, or turning out the distal humerus, or the end of your upper arm. Okay? So oftentimes what happens is that function becomes more involved than, say, extending the elbow, especially with some kind of repetitive activity or whatnot. So the elbow extension function up from the triceps becomes somewhat compromised. So you start to use the nervous system, because of the aggravating activity, starts to use some of the accessory elbow extensor muscles, such as common ones are the anconeus, small little guy there, stabilizes the elbow joint, the supinator muscle, which turns our forearm out, and all the muscles that have their tendons attached to the common extensor tendon, which comes over here, right? So in general, what's going on is, because of that, the triceps are using more of that external rotation demand rather than extension. It creates a compression in the back side of the joint, okay? And where there's compression on one side of the joint, there's an expansion or opening, and that's happening in the front, okay? So on the outside part, where people feel the lateral epicondylitis, there's a expanded position. So the accessory muscles compensating for the triceps are trying to create compression, but they're doing so from an expanded state. So in physical therapy, there's a classic joint mobilization technique to address lateral epicondylitis from Brian Mulligan, old school physical therapist from New Zealand. He came up with the Mulligan mobilizations with movement, or MWM. And one of the things, I'm going to put this down, is you would have the patient take the involved arm, and then you would put the distal humerus, fix it on the edge of a wall or a doorway, and then you would take the other hand and mobilize the proximal forearm and translate or glide the forearm bones laterally while they're squeezing a tennis ball or squeezing something to contract the muscles. And they would do that if it seems to not cause any pain or alleviate any of the pain symptoms they had when they were contracting those muscles. So what I find, or what I think might be going on with that, is that that mobilization, that lateral glide, might be putting or resetting the joints, the bones, with the elbow flexed in a more of a compression position in the front of the joint, an outside part. And then when they contract the muscles by squeezing a ball or something in their hand, they're contracting those muscles in a more compressed position of the bones, of the joints. And it's basically re-educating the nervous system on how to contract those involved muscles in a different position. Now, that doesn't always help or resolve patient symptoms. And when it doesn't, that's why it's a good clinical assessment tool, is that there's other things going on. Meaning there's a lack of variability in the system somewhere more proximal or more close to the body, and say the shoulder girdle, where the shoulder blade is moving on top of the rib cage, and the rib cage and the spine, there might be something going on where the compensation is resulting in the elbow pain. Or it could be more distally at the wrist and the hand, where usually the wrist relative to the hand, there's some kind of a twist going on. One might be more pronated or supinated or internally or externally rotated, and whatever is lacking is being compensated of where they're feeling the pain. Now, this isn't just lateral elbow pain. This could be medial elbow pain as well, golfer's elbow, as they say. But you got to understand the mechanics going on here and above and below. So it's really not a hard fix. It's not a hard diagnosis to address. And you see a lot of this with people who like to lift weights, or manual laborers who are gripping and holding things and working with tools under load or tension for prolonged periods. They start developing these really annoying symptoms. So those symptoms are actually a gift, in that even though it sucks because it hurts, but they're actually a gift because there's an alarm bell going off telling you that there's a lack of variability somewhere else and your body's not able to compensate anymore. And to be able to do what you have to do as far as function and work or sporting activities without pain, it's an opportunity really to find where there's other potential or possibilities or variability, okay? So that's where I come in when it comes to physical therapy or rehab. It's really exciting to discover where a patient is currently and how does that relate to their symptoms, and then what possible variability or possible variety of strategies do they have available to them, but most importantly, unloads the symptomatic area. And that's really good rehab, because once you understand that, then it's just a matter of training the system or training the body how to use those new systems, whether they need manual therapy in the beginning, but that's really short-term, short-lived. You don't need a lot of manual therapy once you're very specific, and then it's really a matter of prescribing the appropriate and very specific exercises that drive that variability of possibilities for them to unload that area. Triceps, back of the humerus here in the elbow. So triceps extends the elbow, but also twists, or external rotation, or turning out, okay? So triceps again from the side, extends the elbow, and then it brings this guy forward, which is an external rotation of the distal humerus, and then relative to that, this guy here, the ulna and the radius, pronate or turn in, okay? Like that.